Good evening, everyone, and thank you for joining us for tonight's Woo You event with Dr. Thanh Nguyen. He's going to be discussing Smile, the next iteration. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So Dr. Thanh Nguyen is a board-certified optometrist at Gulf Coast Eye Care in St. Petersburg, Florida. Dr. Nguyen graduated from the University of West Florida with a Bachelor of Science in Chemistry and Biochemistry, went on to receive his doctorate of optometry from NOVA, and then completed an ocular disease residency at the Baltimore Veteran Affairs Medical Center in conjunction with Wilmer Eye Institute at Johns Hopkins University. He has been focused on the latest advances in refractive surgery during his tenure at Gulf Coast Eye Care, and has recently presented at a collaborative care convention with Carl Zeiss Meditech in 2023. So truly an expert in the field, and we're excited to have him. Here are his financial disclosures, all of which have been mitigated. So Dr. Nguyen, I'll have you take it from here.
Wow. Thank you so much for that wonderful introduction, even though I wrote it. So expert in my field, I have a little bit of imposter syndrome from that, but I'll do my best and hopefully I'll get invited back. Tonight, we'll be talking about some of the latest iterations in the refractive surgery space. We'll go over where we've been, what got us here, as well as discuss like the latest advances in refractive surgery, in this case, mainly SMILE, how it compares with its predecessors, and really dive deep into the science. Finally, we'll have some time, like Dr. Sorenzi said, to open up for some questions. She already mentioned this beautifully. Just some key indicators here is that along with Micah Manning, that we head up the refractive team at Gulf Coast Eye Care, where we specialize in SMILE, LASIK, PRK, ICL, refractive lens exchange. So really the entire gamut of refractive surgery. But this is our peer in St. Petersburg. It looks great. So, being as nervous as I am, I was practicing this presentation ignasium to my dog, who has been gracious enough to deal with me. And he kind of asked me, what is SMILE? So I kind of asked Miriam via Google, and she said that it was a facial expression in which the eyes brighten, the corners of our mouths curls up slightly, as well as it expresses some amusement, some pleasure, some approval, which we all hope for our patients. However, some scorn from time to time, which I don't really understand, but here we are. Overall, it's a pleasant and encouraging experience and appearance, which we all hope that our patients leave with. The developers of VisuMax at Zeiss were privy to this pleasant appearance and got with all of the scientists and all the doctors and all the engineers from around the world and came up with this particular acronym, SMILE. It stands for Small Incision Lenticule Extraction, and you'll soon find out why that is the case. My favorite part about this whole setup is that the bed swivels. So you see that bed right there, it swivels. And you don't really need that swivel function all too much with SMILE, mainly because it's a one-step laser. So everything is done in this particular position. The patient's laser treatment is done here, as well as the lenticule extraction is also done here. But for LASIK, you can make the flap in this position and then swivel the patient over to the excimer laser for the treatment. So, you know, it's kind of like the little things that really gets you excited. So some of the timelines for laser vision correction is in 1995, a jam-packed year. Jordan decided to unretire. You got Toy Story coming out. Amazon was still a bookstore. But also PRK gained FDA approval. Super exciting. A few years later, in 1998, Titanic really captured the hearts and imaginations of the world and made people really question whether or not a door could fit two people. I have my own opinions, but equally dramatic moment in refractive surgery history, at least, is the debut of LASIK from the FDA. Fast forward to 2001, we were able to make better flaps. Fast forward even more to 2016, almost 20 years later. I'm sure nothing happened in pop culture at that time, but in that span, LASIK became the most scrutinized and the most lauded, the most appreciated elective surgery ever developed, so much that it's still the most popular option for refractive surgery today. And year after year, the surgical protocols, the laser technology has improved so much that finally we were able to offer patients a different modality of treatment, and this is where SMILE comes in. So a little bit about the procedure. This is the interface docks at the limbus, super low suction. The lenticule cut is made from the outside inwards, defining the bottom part of the lenticule. Then you have the side cuts, the lenticule, which the cap cut, which is the top part, along with the opening incision, where the surgeon will eventually take out the lenticule. And that's it. Pretty short. This is a little diagram of what we just talked about. Number one, in orange, you have the lenticule cut, which is the underside portion of the lenticule. You have the lenticule side cuts, which kind of keep everything in place. You got the cap cut, which defines the upper portion of the lenticule, as well as the cap opening incision. Some nuances of the cap incision is that in the UK, I think it's a little bit off of the superior mark, so right about like 120 degrees. Whereas in the United States, we have some main character energy where we have it right at the 12 o'clock, so right superiorly. So those are just some nuances of people having it here versus elsewhere. So in order for the surgery to be successful, the team had to really innovate a better way to deliver the laser technology in general. So here are some features of the laser. The interface is a curved interface, so it's just less deformation to the cornea. It's also really important for that particular curvature to align very well with the cornea in order for it to make the precise lenticule cuts. It also had the added feature of a lower IOP, as well as lower corneal suction. So all of that amounts to patients just being a little bit more comfortable during their elective procedure. The interface is also smaller, so it accommodates for smaller palpebral fissures. And since it's at the limbus, it has lower chances of subconjunctival hemorrhages. Some nuances, some additional keynotes about this is the VisuMax has improved flap thickness reproducibility. So right around standard deviations of like 4 to 5 microns. So if your surgeon is planning for a 100 degree or 100 micron flap on like thin LASIK flap, or in SMILE 120 micron cap, they are going to get really close to that outcome every single time. And that's really important for patients who we are mindful and cognizant of their corneal thicknesses. Our current laser times at our clinic is right about 35 seconds for our suction time, and for our laser times, roughly about 30 seconds. So, however, I believe that the latest iterations of the VisuMax, it's even quicker than that, if you can imagine it. So that's pretty wild. We'll kind of address that a little bit later on. So being in the refractive space myself, or if you've had LASIK in the past, you'll notice that although the procedure is really short, patients will most likely remember the suction or the pressure or the momentary blackout in their vision. This is because like the current iterations of lasers, it docks right at the sclera. So it kind of increases some of the risk of subconjunctival hemorrhages. The suction's a little bit higher as well. So benefits obviously is that there's lower chances of losing suction. However, it's just a little bit uncomfortable for patients. in this particular situation, the interlace goes up to about 150 millimeters of mercury when we talk about increases in their IOP. The FemTech goes up to 200 millimeters of mercury. The Femto LDV goes up to about 175, whereas the VisuMax has one of the lowest suctions at 85 millimeters of mercury in terms of its IOP increases. And what that does is it maintains that intraocular circulation, which allows for patients to keep their vision and don't have that momentary blackout. And lower incidence of subconjunctival hemorrhages. So if you're in a profession where you're face to face with a lot of people, it's just an extra added benefit. I mean, it's not really that big of a deal. These subconjunctival hemorrhages really resolve pretty quickly. But like I said, it's like the little things that matter when patients are already going through an elective surgery. So these are some of the FDA indications for SMILE. Right off the gate, first thing you'll notice is that there's no hyperopic treatments for SMILE. So SMILE's refractive errors treatment areas are -1 to -10. The astigmatic is -3/4 to -3. So patients who need a hyperopic treatment, that's a fantastic opportunity to pivot over into LASIK or PRK. You also notice that SMILE is indicated for patients who are 22 years of age and older. And I think LASIK and PRK is 18. However, you're still able to do SMILE in 18-year-old patients. It would just be done off-label if all of those other parameters are met. And this is perfectly fine because it really, with these particular parameters, it already covers roughly about like 80 to 90% of the population who are interested in refractive surgery already. So you shouldn't have too much big of a problem. These we've all seen before, but I just want to touch on some highlights of preoperative considerations. Is that manifest refractions, what we are extremely good at, are incredibly important for pre-ops as well as post-ops because we want stability. Stability is the name of the game. We don't want to go chasing a moving target. So we want patients to stabilize before we consider doing anything. Post-operative refractions are really important because it allows the team, mainly me, in some situations, the opportunity to fine-tune the nomograms and improve patients' outcomes. Topographies are obviously paramount, and if there's any weird patterns that you see, a good option to consider is like an epithelial map or an ARC scan, which is basically like a high-resolution anterior seg scan. So all of those things, really important. These contraindications we've seen before. Also, something that's relevant to our day-to-day practice is stabilizing the ocular surface. So we can optimize patient outcomes as best as we can. So whether it be artificial tears, immunomodifiers, low-dose steroids, hot compresses, IPL, intensive slight, or LipiFlow, all of these things, we need to utilize everything in our arsenal to really stabilize these pre-existing dryness conditions so patients are able to start off on a really excellent footing. So SMILE is LASIK-like outcomes with one-step minimally invasive procedure. So SMILE is roughly about a 60-degree incision, whereas LASIK is a 300-degree flap cut. So overall, it's a smaller incision, which leads to potentially better biomechanical cornea. So everything is much stronger. This also leads to a better intact corneal nerve plexus, which affects a lot of the dryness, which we'll also talk about that a little bit later. This is a little video, which I hope I can play. This is a real life, one of our patients. And first off, you have the lenticule cut at the bottom. Patient is looking at that green light the entire time. Then you'll have the side cuts, which keeps everything intact. Then Then you have the cap cut going from outside or inside outwards. And finally, you have the opening incision right at the bottom. That's how you know you're in America. Next is a little bit of the surgery. Dr. Manning will do an anterior sweep going in from that opening cut. Then you have the posterior sweep to identify the entire lenticule. I'm going to fast forward this just a smidge. Then he's going to take this little spoon spatula looking thing, and Dr. Manning's going to dissect above and below the lenticule. There's these little tiny little tabs around the perimeter of the lenticule that kind of holds everything into place. So while Dr. Manning's doing this, you'll see that he'll be breaking those tiny little tabs to free up the lenticule. And we're going to sweep, and we're going to sweep, and we're going to sweep. I'm going to fast forward this just a smidge more. Do some more sweeping. At the end of this, towards the bottom here, you'll notice that he'll take out the lenticule and rehydrate everything. And then he's going to place the lenticule that he's taken out and make sure and confirm that everything is taken out in its entirety. All of that roughly about, 2.5 minutes per eye. So roughly about 5 minutes. And this is the incision that you see. I'm trying to find it here. This is the incision that you see. And it's the video going over the incision. And what we want to look here is we want to make sure that there's just no nicks, no abrasions that we have to put like a bandage contact on or anything like that. Vast majority of times, everything comes out pretty smoothly. Blinded the patient there. Okay, so this was that particular patient, IRL, in real life. She was a 24-year-old female, a flight attendant. So this patient was very cognizant of the cabin dryness. So SMILE was really appealing to her. She's obviously an ideal candidate. And after the SMILE, she was right back to her work. 3 days out, she was 20/20. So she was doing fantastic. So some of the recovery processes really aligns very well with LASIK. So, day out, you're able to go back to work. A few days later, we see the patients back. Oftentimes, we kind of do this like later on in the week, so like Thursday or Friday. So, we don't have to go to the clinic on Saturday to see them because there's no flap to inspect. There's no bandage contact lens to take out after a week. So all of this is very convenient for the patient as well as ourselves. So like I said, no flap. So we see the patient 3 days out, 1 month out, and 3 months out, and then obviously at that year mark. Medications and artificial tears, very similar to LASIK or very similar to LASIK. You have your antibiotic of choice. You have your anti-inflammatory of choice. We just want patients to kind of wear a little shield before they go to bed just for that day, but they can resume all of their normal everyday activities. So it really aligns very well with our patients' busy schedules. This is really my favorite slide of the entire presentation. We as practitioners know the success of LASIK. We know that LASIK has been the most scrutinized elective surgery since it came out in the mid-90s. So today, it's still a fantastic option for laser correction. So when SMILE came out, all the engineers and all the scientists and all the doctors really had to be cognizant of this. They made the bold play to put it head to head with LASIK. And it definitely worked. It delivered because of this. It gave us the advantage and the opportunity to talk about these two particular procedures as really colleagues and not so much rivals, because it bears out in the data. That brings me to my next point, is that we must talk about these two particular procedures in terms of their equivalency, because it's in the data. Because if you're co-managing as the co-managing optometrist, doing like a screening it's difficult to predict the best option without topographies, nomograms, laser settings, or even any intraoperative decision-making that would make the surgeon consider pivoting to one procedure over the other. Like maybe the patient has a prominent brow, blinks, moves around, docking loses suction. Some of these variables were just intrinsic to the surgery that we just can't necessarily predict as someone screening. So we want patients to come out of everything with the same amount of enthusiasm as they go in. And that's why I love this slide so much, because all of this data really shows that regardless of the procedure that the patients pick in terms of visual outcomes, they are going to have a fantastic result. So moving forward, spheral, cylindrical, very similar between SMILE, topo-guided LASIK, as well as wavefront guided LASIK, very similar outcomes. And all of this data and success really stands out when we see how many procedures have been done worldwide, right? 2022, all the way up to about 7 million. Last year, it crossed over into the 8 million procedure mark. So that's really exciting. And we find this as the case for our own practice as well. We started out pretty slow because at the beginning we were trying to figure out some of the laser settings. So initially patients were kind of coming back 3-day post-op at like 2040-ish. And we were like, man, what's going on here? And that's really hard to justify to the patient when they're comparing it to their LASIK friends and family, right? But eventually, these patients still had fantastic outcomes, but it just took them a little bit of time to get there. So after like some tinkering around and some guidance from like our colleagues as well as the Zeiss team, we finally lowered the energy settings significantly. And that's when things really took off for us. You'll see this giant trajectory here. And patients at the 3-day post-op period were certainly comparable with LASIK at that point. And moving forward, we just never looked back. As a practitioner, one of the main reasons why we prefer prefer SMILE in vast majority of cases as our first option is just the enhancement rates are super low. In this particular study, you have it at about a 1 to 7% enhancement rates, where the enhancements were done with PRK, which certainly is an option, but there's other options when we want to consider enhancements as well. This next one was done in Singapore, and it showed an enhancement rate of roughly about 3%. These are numbers from a very high volume refractive practice in South Korea. And it certainly makes sense that once you fine tune some of the nomograms, the enhancement rates are even lower. LASIK and PRK tends to be a little higher, and some of that thinking behind it is because it's just the open system that LASIK and PRK treatments have to go through relative to the closed system that SMILE goes through. LASIK and PRK, you have to really account for some of the under and over corrections related to like variabilities in like humidity, the corneal status, whether or not it's like dehydrated or not. Sometimes whether or not the laser is like running hot or colder that day would lead to like under or over treatments. Whereas with SMILE, because that entire treatment is done within the cornea via the lenticule, these variables are less of a consideration. So the common question is, does it wear off? Not necessarily. I mean, there's other aspects of our eyes that do change over time. So, I mean, we already know this, lens changes and whatnot. So we know about some of these milestones already. Dry eye associated with refractive surgery is a topic that we can fill like an entire lecture on its own, but here are some highlights associated with SMILE at least. 1 month out, SMILE and LASIK are certainly improving. Tear osmolarity is a little bit better in SMILE than LASIK. I think like a normal measurement is roughly like under 300. But if you can see at the 6-month mark here, all of the SMILE metrics improved, whereas LASIK is virtually unchanged. So we can theorize that it's still healing overall in terms of that corneal nerve plexus, which brings me to this next fun picture. A lot of that, we alluded to just now about the corneal nerve plexus. With LASIK, because of that flap, it severs a good chunk of that corneal nerve plexus, whereas SMILE with that 60-degree incision, it basically just kind of shocks the cornea. So removing some of the central cornea sensitivity to baseline was reached right at about 6 months with SMILE. So because LASIK has that 300-degree flap, like I said, it severs a lot of that corneal nerve plexus, and it just takes much longer for things to regenerate. Like it takes like 12 months, you can see from that red line, to regenerate. Whereas with a 60-degree incision, about a fifth of the size, the cornea is just kind of shocked, like I said. So about 3 months out, you're close to baseline, and at 6 or 7 months, you're back to normal again. This is a computational model that a lot of smart people in Ohio and the Cleveland Clinic did. And they found SMILE to be biomechanically stronger than LASIK. Dan Reinstein over at London Eye Clinic measured the corneal tensile strength of SMILE and PRK and LASIK, and they found that SMILE has a higher tensile strength because it left like the strongest anterior stromal lamella intact, followed by PRK and LASIK. These measurements are pretty sophisticated, so if you want to like hear more about it, Dan Reinstein has a good YouTube channel. You can look for it yourself. He lectures a good chunk about refractive surgery and the cornea overall, so he's a fantastic resource. Overall, why is it important to our patients? It's convenient in terms of its scheduling, potentially less dryness than LASIK, faster recovery in terms of corneal sensitivity. Because there's no flap, a lot of martial arts patients or a lot of like sports or occupational patients prefer SMILE. And we know that contact lenses are really a great option for patients, really. So like not every patient is going to want to have an elective surgery. And the vast majority of the patients who do well with contacts just stick them where they are. They do well. But there's about a 25% of patients who want another option, who are contact lens wearers. So for those contact lens patients, their contact lenses are like uncomfortable, they're dry, they're irritated. And instead of them just being unhappy or dropping out altogether or having someone else tell them about SMILE or other options, you can be the doctor that says, hey, you have other options other than, contacts that you don't necessarily like, that if you want to get out of glasses in general. So that's a fantastic option for patients. We know that contact lenses also comes with some risk. Patients sleep in them, they overwear in them, yada, yada. And it could form this keratitis that, has a faint scar that you could see could disqualify patients from SMILE, mainly because the laser energy used for SMILE is much less than LASIK. So it's just not able to penetrate those particular scars. In these particular patients, LASIK or PRK or even ICL, if they're a candidate, if their measurements pan out, could pivot to if they want to reduce their dependency on glasses. So we went through this. We know that people are very happy with LASIK in general. And that's why, over the past 30 years or so, they continue to get it. And I would imagine that SMILE would be very much the same over the next 30 years as well. In this particular study, you have a control group that just stayed in contacts. And over time, they got a little bit unhappy. Patients who pivot over to LASIK from their contacts, they are significantly happier. Patients who were in glasses and pivoted over to LASIK, they were also happier. So we know that there's certainly patients out there who would benefit from these particular refractive surgeries. So it kind of bears out the benefits of LASIK, right, compared to SMILE. They got similar outcomes, and it bears out in the data. Availability is paramount also for LASIK because it's pretty ubiquitous. Surgeons train on LASIK vast majority of the time, so it's super available, mainly because the VisiMax at this point is the only laser that can perform SMILE. Name recognition, right? Patients have family, they have friends who've had LASIK, so sometimes name recognition is a priority for them. It has a proven track record, obviously, that we alluded to, and it can have the potentiality to treat these corneal scars or these faint corneal scars as well. Benefits of SMILE, obviously. Just because something is super successful like LASIK doesn't mean we can't improve upon it. And that's where SMILE comes in. It has similar outcomes to LASIK. It has one laser. So, although I love that swivel bed so much, no need to swivel. No flaps. So it's great for patients, like I said, in martial arts, occupations, who are like more active and downfield because it has no flap. Potentially better biomechanical stability, faster recovery in terms of returning to their normal everyday activities. There are less inductions of higher order aberrations, which we didn't touch on too much here, but it's true. And less dry eye issues when compared to its counterparts. And the truth of the matter is that OD's optometry is really important. We are the primary eye care professionals. We are whom the vast majority of patients and people have their first exposure to eye care. As of 2022, there's about 2 optometrists per every 1 ophthalmologist. And the Association of American Medical Colleges anticipates that there will be a deficit in ophthalmology by next year because of whether it be residency slots or people retiring. So someone has to kind of step into that role to kind of fill that 6,000 deficit. And we are in a fantastic opportunity to fill those particular roles.